good pickup there. So speaking of Lurbi, really curious in terms of your experience with it. A lot of people are asking about. The average oncologist has used it, but not that much, certainly not as much as you have. Here's one case from Dr. Mohamed, a 68-year-old woman who had disease progression after chemo IO and then got second-line lurbinectedin.
I put her on the lurbinectedin, and she's now 3 cycles. She actually having good response in the liver, stable disease in the lung. My question, what's next if the patient would like to continue on further treatment if she progresses?
How does she tolerate it?
It's myelosuppressive, but it's not as bad as any regimen used in small cell lung cancer. Nausea, vomiting is not really that bad. It's another alkylating agent. She's like my 3rd patient to use it.
Any quality of life side effects that you've seen?
Not actually. It's much easier than what I would have used, actually much easier than the cis and the reno that I used. So it's actually, this is a break for her compared to what I used before. I think every one of us only have a few patients and short duration of follow-up. But if they have used it in clinical trial, how far can you go with that? Can you stop at certain point and give a break and resume again?
So, and this is a paper, one of a number of them out there reviewing lurbinectedin. We like to put review article papers in our slide set so people can then read them. First of all, maybe comment a little bit about the mechanism of action of the drug.
Yeah, so lurbinectedin has a couple effects. It impacts polymerase II, so stalls RNA polymerase II, allowing for DNA repair. But it also impacts the tumor microenvironment. And so tumor-associated macrophages actually have an effect of increased inflammatory markers, increased VEGF within the tumor microenvironment, and it tends to clear out, leading to apoptosis of tumor-associated macrophages, therefore presumably decreasing the level of VEGF expression, decreasing the inflammatory markers, and therefore decreasing the vascularization of the tumor and such. So it acts in a couple of different ways. In the case, he was asking about next after lurbinectedin, or did you want to dive into lurbinectedin in particular? I see you pulling up that basket trial.
Yeah, well, I'd like to, I think everybody would like to hear your experience. He wanted to hear an investigator's experience with the drug, in terms of efficacy. Have you seen good responses and tolerability in general? What do you see in terms of tolerability? Of course, we have a bunch of data looking at this. Looks like some of these responses are pretty for a fair period of time. First of all, what's your clinical experience with the drug?
Yeah, so similar to the published data, and I think this is a good swimmer's plot here. This is showing you the duration of responses that we're seeing, and you see there's the red and the blue, and this is a cutoff based upon the chemotherapy-free interval from first-line therapy. So topotecan is approved IV with a 60-day chemotherapy-free interval, and PO with a 45-day, just based upon how those trials were done, whereas lurbinectedin is approved across the board, irregardless of the chemotherapy-free interval. Again, that chemotherapy-free interval is from the first-line platinum-based chemotherapy. So there are patients with in this group, you see one of those with a blue, and so I think that was what was called resistant. I think it was a 90-day cutoff point. So, these are patients with the more aggressive, more resistant disease. Now, in that group, we certainly did not see as good a results numerically as what we see in the group with a higher chemotherapy-free interval, and that's true of all cytotoxics across the board. I think this drug, similar, if I'm using my prior analogy where the checkpoint inhibitors are like swinging for the fences, trying to hit a home run, where you have a limited number of patients that really get that benefit, but the benefit's overwhelming. In this case, lurbinectedin is really like swinging for a single or double. There are a number of patients that really get benefit from the drug. You see overall response there of 35%. I've increasingly seen disease control rate reported. I don't know what to make of that in non-small cell lung cancer so much. But in small cell lung cancer, when you have stable disease, I think that's generally pretty meaningful. That's not to say that I think that everyone who had, every one of those 69% of patients benefited from the drug. There are probably some patients in there that had a scan that was technically stable disease, but maybe wasn't really benefiting and just happened to be a less aggressive kind of small cell. Sometimes there are some of these patients within our small cell trials, just based upon the challenges in enrolling. But generally speaking, that does mean there certainly are patients within that 69% that were stable disease that were benefiting from the drug. And my experience has been similar to this. I've had a number of patients with responses to therapy, including some who had really rapidly progressive, very aggressive small cell with a very nice response to treatment on lurbinectedin. And then at the time of progression, it was very rapidly progressive again. So really just an absolute demonstration of benefit from the drug. It has generally been very well tolerated. Cytopenias are certainly something to monitor. And in the trial, I think it was around 46% of patients that had grade 3/4 neutropenia. Oh, yes, it's 46% grade 3/4 neutropenia. The trial did not allow for GCSF. At the time of initiation of therapy, though, so that number would presumably be less in patients who were getting prophylaxis, and so that's something certainly to consider. One thing to point out, though, is in that trial, 7% of patients had a grade 3 fatigue. And at the initial time of looking at the data, I thought, well, maybe some of that was people where the treatment wasn't working well enough. And so this is, people with small cell lung cancer and other comorbidities. But I have certainly seen some patients, one in particular, who really had severe fatigue despite clearly benefiting from the drug, having a very nice response to therapy, but had such fatigue that I had to stop his treatment. I couldn't give him any more lurbinectedin, but even after stopping the treatment, he had another 4 months of disease control before then having rapidly progressive disease again that was really resistant to any other therapies. He got 2 other lines of therapy after lurbinectedin, neither of which really touched his cancer, unfortunately. So, what we're seeing with lurbinectedin, I think, is months of clear clinical benefit to a decent enough percentage of patients to warrant this as being, I think, a good option in such a challenging diagnosis. So it is something I commonly use in the second line. If someone got a irinotecan second line or a topotecan second line, you could consider it third line. And I think it is a reasonable shot at a single or double using this analogy I've been using.
And Michael in the chat room looked up, and we looked it up too, that it's actually not a black box warning in terms of ILD or pneumonitis. It is mentioned in the package. I guess there was a case of it, but in any event, that's the follow-up on that. What about this study? This has caused a lot of interest, maybe / confusion. We saw some more data, more analysis from this at ASCO. Doxorubicin combined with lurbinectedin, phase 3 trial, and then what they presented at ASCO looked at the patients who continued on after the doxorubicin from responding, continued lurbinectedin and monotherapy. But this study ended up being negative, and I guess people are trying to figure out how to interpret it. I think the dose is lower. What was your take on it?
Yeah, I mean, anytime there's a negative trial, it's disappointing. But this is something, to your point, that the dose level was 2.6 in this combination when giving it with doxorubicin versus 3.2 when it's given as a single agent. Of course, I'm talking about lurbinectedin. And that dose level may be extremely important. Now, in this, I think it clearly demonstrates there's not enough of synergy in response in combination with doxorubicin. Yes, the data did show that was presented showed maybe there was increased benefit when going into the lurbinectedin maintenance, which is the higher dose of lurbinectedin. So that being said, that is not at all to say that, oh, maybe this combination, that's not a statement for the combination. I think what that reinforces is that the dosing, the pharmacokinetics of that may be really important, and that higher dose of lurbinectedin may be very meaningful when we're seeing someone who's had a response to combination therapy that then goes on to have a deeper response so far into their treatment after going on to single agent. I think suggests that there's some kind of benefit to be gained. you know, we don't tend to see someone who's so far into their therapy suddenly end up with a bigger response to treatment. So I think it somewhat reinforces this idea that dose level is really important, and going lower dose maybe really limits benefit to the lurbinectedin component. Clearly, lurbinectedin, doxorubicin, is not something to pursue further, but what I'm describing is something that plays in my mind when I'm treating somebody on single agent lurbinectedin, and I'm more hesitant about dose reduction. Of course, I will do it if it's warranted, but if there's another way around it, if somebody has not been getting GCSF, for example, and the reason to consider dose reduction is prolonged neutropenia, well, that's someone who should get GCSF, and then I try and maintain the dose if I can. So I think it is relevant in that respect in considering that dose level. Unfortunately, the combination is not really something that's going to be pursued further.
So here's we showed the data from ASCO looking at these patients who went on to the monotherapy and seeing their response increase. What about new trials? Of course, anytime everything gets combined with an IO, particularly chemo, looks like you had this Looper study kind of beginning to look at that. Also, lurbinectin combined with irinotecan, really interesting idea from the Lagoon study. Any thoughts about where things are heading? I think there's also, we have this paper. Look, this is kind of a cool idea, looking at lurbinectin as part of maintenance of first-line treatment. Any thoughts about some of these new strategies?
Yeah, I mean, these are essentially, it's taking lurbinectedin. The side effect profile of lurbinectedin is really, for the most part, just the cytopenias. So you can really combine it with a number of different things, generally pretty well tolerated. And essentially, these are all trials of combining lurbinectedin with other treatments that are commonly used within small cell lung cancer, irinotecan being a common agent, as we've discussed. The maintenance setting with checkpoint inhibitor, another. There's also a recent phase 1 that showed tolerability of paclitaxel plus lurbinectedin, and so that would be another. And so we'll see. You know, these are just other swings at combinations. Hopefully, we will see real deeper benefit with some durability by combining these.
So I was wondering whether we could talk about small